Okay, I think we are ready to get started. There might still be some people filtering in, but we are 5 past or so it's a good time to start. We'd like to welcome everybody to today's seminar on sustainable development. It's a great pleasure to bring back Irwin Redlener and a panel of distinguished guests and Colombians to talk for a second time on the Ebola crisis. Some of you might remember that we had an event in the fall semester when the Ebola crisis just had emerged and when things were sort of still playing out, when it was not clear how widely spread it would be, what could be done. And since then, it actually got fairly quiet around it, but that doesn't mean that the whole puzzle has been solved. So I think it's actually an opportune time to revisit that in the context of other diseases, because Ebola is probably not the only one that we will experience. And Irwin and the National Center for Disaster Preparedness that he directs were willing to pick up that topic and debate it in a panel form, and then, as we usually do, we will have a discussion after initial presentations. So we have a great set of scientists and scholars and practitioners who work on this topic, including Arturo, Brito, Robert Klitzman, Jeff Schlegelmilch, and Irwin, who will moderate the session. Irwin will introduce the speakers to you, and but to start off, I will introduce or reintroduce to some of you Irwin. Before doing that, I just see that I have a note on my sheet here that I made, and that is that there are flyers on the back table on a program that's led here at Columbia University by Robert Klitzman on bioethics. So feel free to pick up one of these flyers on your way out. It's a very interesting program, and the flyers will tell you what it is. So let me introduce Irwin to you. As most of you know, Irwin is a medical doctor by training. He's the director of the National Center for Disaster Preparedness, which is part of the Earth Institute. And he works to understand and improve the nation's capacity to prepare for and respond to and recover from disasters. He also directs the Earth Institute's program on child well-being and resilience, which is an interdisciplinary academic center to support greater understanding of the issues, challenges, and opportunities involving children and youth. Irwin holds professorships in health policy and management and in pediatrics. I think that was actually where he came from pediatrics. As most of you know, Irwin pops up on TV, radio, here and there. Sometimes I drive in and I hear a voice and I say, it must be Irwin. And sure enough, there is something out there in the world that needs some expert advice, and Irwin is frequently asked to comment and to get us oriented on what is playing out in the world. So he is well recognized for his expertise on disaster preparedness policies, on pandemic influenza, the threat of terrorism in the US, the impact and consequences of major natural disasters and related issues. So you can see a very, very broad set of topics, all of which are actually of great interest to the Earth Institute and looking for a sustainable future. He holds a lot of very important appointments. Following Hurricane Sandy, he was appointed by Governor Andrew Cuomo to co-chair the New York State READY Commission. He also recently served as one of the 10 members of the congressionally established National Commission on Children and Disasters. In 2014, he was appointed as special advisor to New York City Mayor Bill de Blasio. Finally, if you are somebody who likes to read books, Irwin is the author of Americans at Risk, Why We Are Not Prepared for Mega Disasters and What We Can Do Now, which was published in 2006 by Knopf, a good book to read. I can highly recommend it. And last thing, Irwin is president and co-founder, and he founded that organization, the Children's Health Fund, together with Paul Simon, which is a philanthropic initiative created to develop healthcare programs in 25 of the nation's most medically underserved urban and rural communities. So you can see we have somebody with great experience, great depth of knowledge, great breadth, and I'm really happy that he made the time to lead through that session. So I would like to welcome Irwin to the podium to introduce his speakers.
Thanks, Peter. Good afternoon to all of you, and thanks for that eclectic introduction. Some people call it ADD, but thank you for complimenting it. Anyway, so yeah, this has been quite an odyssey for us. That is the National Center for Disaster Preparedness, which began here at Columbia in 2003 in the aftermath, really, of 9/11, but really sustained through quite a few other disasters that you're all well aware of that seem to be proliferating as time goes on, and maybe they are, maybe they aren't, and all sorts of fundamental changes occurring that may unfortunately present with more disasters as time goes on, but that remains to be seen. Today, though, we're going to focus on some questions. I just have 2 slides to show you. One is that I just wanted to set the stage here for the discussion, then I'm going to introduce the speakers. So we're going to be talking about ethical challenges in disaster planning, response, and recovery, and we're going to be using the situation with Ebola as, in essence, a case study. And it's a case study because it represents or presented many of the problems that are common in disaster response management and so forth that confront these fundamental challenges. For example, the reality of scarce resources, which is almost always the case in a very large-scale disaster. And when you have scarce resources, somebody or some process has to determine how those resources are distributed and utilized. We also confront the fact that we don't really have often enough data-driven or evidence-driven information to drive our decision-making. And that is a real problem, too. So that leaves some of the decisions that we're going to make under these highly stressful situations up to some level of consensus or arbitrary or subjective or experiential information to drive those decisions, and that's not ideal. Thirdly, in the case of Ebola, there were quite a few very explicit dangers to the context of the people that were trying to help, and obviously to the healthcare providers or the care providers generally. And I mean both the care providers, the formal care providers, the doctors and the medical staff, but also the informal care providers and neighbors and others that also might well have been exposed to somebody with Ebola. And this presents some challenges in terms of who we're getting to care for people and what goes into those decisions about whether somebody will or won't put themselves in danger to help other people. And then, especially in places that are disadvantaged or under-resourced generally, and by the way, even when in a developed country, when there's an extreme event, there are all kinds of questions about the standard of care that we use. Are we allowed to call for a reduced standard of care because pressing needs make the things that we'd rather have not available or not accessible? And therefore, we have questions about the quality and the quantity or the place of care. Do we transfer everybody who gets Ebola out of West Africa? We obviously cannot do that. But some people did move out of harm's way, and who are those people, and how does that happen? Why does that happen? The development of countermeasures to specifically address, like the Ebola virus, those countermeasures are limited, and the resources to develop them are limited, and decision-making about which countermeasures would be developed and which won't be remain decisions that are of societal import, but really do confront some of the other challenges that we have in society, which I'm just going to mention in a second, particularly this one, which is that there's a basic incompatibility between a capitalistic, profit-oriented reality in terms of, let's say, producing vaccines or medical countermeasures with a pure public health agenda. Because if all we cared about was a pure public health agenda, we'd probably have a very different pharmacopoeia and availability of medications, vaccines, and so forth. So this is something I still keep in the realm of ethical challenges because they're societal challenges and we don't quite have a handle on that. And finally, the issue of science versus a whole range of other factors which may influence decision-making, which include cultural beliefs and ideology, politics, the presence of social media that is developing, exacerbating ideas, concept, memes that come into play when we're dealing with decision-making on the citizen level or even in the professional and policy-making circles about what are we doing and how are we doing it. So these are the things that I think were all, and in addition to others that I haven't mentioned, brought up by the Ebola situation we just got into. But the other slide I wanted to tell you is just some more general things about disasters and ethics. First of all, as I indicated initially, disasters are inevitable. They may well be worsening, and I think we're going to be confronting these kinds of situations basically forever. Natural disasters, industrial accidents, terrorism, climate change, they're all the precursors for the fact that we are going to have to increasingly, hopefully, get better and better at dealing with the preparing for and the responding to disaster and recovery from disasters. And every step of the way, we're going to be confronting questions of ethics and values and priorities that will be challenging. And the challenge that we're facing, especially in this ethical arena, in some ways, maybe even more than the direct responses, are very difficult. They're more complex than the other challenges that we deal with. And they're probably the category of ethical decision-making is most avoided because they're the most difficult things to make, which is why we are very happy that we have such a distinguished panel who's going to try to shed some lights here. But the decisions driven by cultural norms, by legal constraints, by the difficult realities I just mentioned in the previous slide, are all part of the equation. How much outside assistance do we call to a disaster scene? When do we call it? How long did they stay? There was just a little flap of controversy. You may have missed it in the paper about the fact that the United States was withdrawing its troops from West Africa, even though we're there for several months and building facilities and so forth, and helping out with the surveillance and direct care of people. We brought those troops home, and people said, why did we do that? And there are reasons, and maybe we'll get into that later, but these are all parts of the decision-making of who, what, and where. You know, Fidel Castro offered Cuban doctors to us around the time of Hurricane Katrina in the Gulf. It was more or less politely declined, but, you know, we probably could have used a little outside help. I'm looking at Arturo, but that's funny. The other sort of big issues are that the fact is that in disasters, these decisions, whether driven by ethical issues or medical countermeasure availability, et cetera, the fact of the matter is lives are at stake. It's not a mega disaster if there aren't lives at stake, and this is the reality of it. And ultimately, a lot of these ethical decisions come down to who gets to prioritize which lives are first in line for services. Some years ago, when we were doing a lot of planning nationally and locally about pandemic influenza, you know, a real major pandemic like the 1918 Spanish flu, where we have a shortage, by the way, now of mechanical ventilators to help people breathe that are in respiratory failure. Lots of discussions about when would the doctor decide to take the ventilator off of me and give it to you? And what are the factors that will go into that unbelievably horrifying decision that we don't really have a grasp on, but maybe we'll address a little bit of that also. And I having been a former director of a pediatric intensive care unit, I think that disasters in our lives are to business as usual as ICUs are to routine healthcare, meaning that, you know, we're sort of going along or doing our thing every day, and then a disaster happens, and everything sort of gets turned upside down, and all eyes on the situation, which has to get dealt with, and you don't have time to wait. You can't put off the decisions. Like a patient in ICU who's having an issue, a decision has to be made. Whether you do or don't have enough information, whether it's evidence-based or experiential, whatever it is, no decision is a decision, and the same is true in a disaster. We have to think and we have to act whether we want to or not. And this, of course, drives things at a rate that is really not seen in our day-to-day lives. So with that, let me bring up the panel here. And so first of all, Bob Klitzman, if you could join us. Dr. Robert Klitzman is professor of psychiatry. He directs the Masters of Bioethics program here at Columbia and the Ethics, Policy, and Human Rights Core, as well as the HIV Center for Clinical and Behavioral Studies here at Columbia. And he's a very distinguished ethicist who's in the middle of a national speaking tour, but fortunately he was in New York today. Second will be Arturo Brito, who's also a pediatrician. Arturo, if you can join us. Arturo is actually, as we speak, the Deputy Commissioner for the Public Health Services branch in the state of New Jersey. So he's been very, very involved in a lot of decision-making and policy-making relative to Ebola in particular. Arturo has had a long experience in dealing with primary health care for children in all sorts of very interesting public health settings. And he was a member of President Clinton's National Bioethics Advisory Commission during the Clinton administration. And finally, Jeff, if you can join us, Jeff Schlegelmilch is the Managing Director for Strategic Planning and Operations for our National Center for Disaster Preparedness. He has, in addition to his other credentials, a well-earned MBA, and I'm mentioning that because Jeff has a special interest in the interface between the public and private sectors, and obviously a particularly germane issue when it comes to understanding decision-making and other issues, related issues in disaster preparedness and response. So with that, I would like to ask Bob if you can kick us off and go from there.
Sure. Well, thank you very much for inviting me to speak. I think this is a great opportunity to examine some very critical issues that, as Irwin said, will increasingly be with us. So thank you to the organizers. Thank you to Irwin. I look forward to having a chance to talk with my co-panelists and to hear from you all, since these are issues often that, as Irwin suggested, that don't always have answers. And I think one important aspect of ethics is not only what the answer is, but how we get there. And in this case, I think that transparency and involvement of multiple stakeholders is key. I should also apologize in advance that I have to actually go teach at 5:15, so I'm going to have to leave a little before the end, but it's not for lack of interest. I thought I would touch on a few things. As mentioned, I direct a Masters of Bioethics program, and some central principles of bioethics are issues of autonomy, that we respect people's rights to make decisions for themselves, and we believe in beneficence. We should try to do good. We believe we should try to avoid harm, so-called non-maleficence, and we believe in social justice. And these principles, however, come into conflict in the more difficult issues that Ebola presents to us, and I'll talk about why and how. And I would say that there are sort of three major areas where ethical issues come up with regard to Ebola, particularly when we start to think about what are the lessons from what we've learned so far, and what are the key ethical challenges as we go forward from this point. And I think that there are ethical challenges around policy, that is government policy and international organizational policy. There are challenges about clinical care, as Irwin alluded to, and there are a lot of challenges about research as we figured out what kinds of interventions, be they vaccines or drugs, that may be effective here. How do we go about seeing if they work, if so, which work, who should get them and when, et cetera. And I would say that I think in part of, just to stand back for a second, I think part of the reason we're seeing so many disasters is that these are unanticipated consequences of the great technological advances that we've had over the past few decades, if not longer. So we now can travel from one location to another. We're, of course, having climate change that appearances are is due to human involvement because of other technological advances that we've had over the past few hundred years. And the fact that we're moving as rapidly as we are across national borders is part of the reason why we've seen a series of epidemics like this, be it SARS, be it H1N1, et cetera. I think with regard to government, I think that one issue that's, I think, riveted the public imagination much of the time with the way Ebola has been covered is that between individual autonomy and the good of the whole. And I'm talking specifically about the cases where there have been individuals here in the U.S. who have been exposed to Ebola, or in one case had Ebola, and at what point do we constrict their individual liberties in the name of the public good? And that, of course, is a very difficult issue because we believe in autonomy. We don't believe in locking people up against their will if we don't have to. But in the name of the public good, at times it's necessary. So if I had Ebola and was busy coughing or sweating or having other excretions that you may be exposed to, of course it makes sense for all of us to quarantine me. The problem is, I would say, is that once that decision gets made in a political context, you have other political factors that are not public health factors, that are not scientifically valid or evidence-based factors that get involved. And this is where that equation gets screwed up. And this gets down to the issue of who's going to make this ethical decision of when is someone so much at risk that they should be quarantined. So, for instance, I personally look at decisions by Governor Christie, for instance, and other governors to let's sort of seal off our state. And here's someone who may have been exposed to Ebola, even though there's no evidence they have it. We're going to kind of wall them off. We're going to have all kinds of restrictions. I think play is a result of the politics of fear and people playing, politicians playing on public fear for various reasons. And I would say, just as in terms of consistency, not to be overly political, and with due respect to my colleagues who are working at a state level in evidence-based ways, when it gets to political figures, for instance, they may say, well, you don't have to vaccinate your kids against measles, which we know is a very effective public health intervention, is to do vaccination, so we're going to not follow public health advice there. But we're going to, in the name of public health, we're going to lock people up who may have been exposed to Ebola. I think reveals some of the ways in which political responses are not based on wise, scientifically informed public health decisions, but other political agendas. I think WHO, unfortunately, did not step up to the plate as it should have. I think an important lesson and set of questions is why Médecins Sans Frontières, Doctors Without Borders, MSF, was able to be so much more effective in realizing that there was a crucial epidemic going on, that this was different than past outbreaks of Ebola by orders of magnitude. They tried raising this for several months before the WHO took notice of it. WHO, for its own, as I understand it, internal political reasons and its own politics of who gets to be involved in WHO at various local levels, did not respond as it should have. And I think, again, I would argue that political factors got in the way of what should have been much clearer ethical thinking about what are the needs, what is going to produce the most benefit, how can we avoid harm, that those ethical concerns and principles got swept aside in the name of other agendas, which I think is unfortunate. I think there are a number of issues currently that I think need more attention about current research that's going on. So, as many of you may know, the overall number of cases is no longer going up like it was, which is great. It's disappeared essentially in Liberia, as I understand it. However, it still continues, and there will no doubt be other outbreaks of Ebola. I think this is something like the 15th or 17th outbreak in the past 20 years or something like that. But there are some interesting challenges. So about 2 or 3 weeks ago, a month ago, it was announced that favipiravir was found to be effective as a treatment as I understand it, about 15 to 30% effective for people who have low to middle levels of virus in their system. The question is, what do we now do with this? So let's say we have 5 other trials going on. Do we cancel the other trials because we now have a solution? Well, it's not a full solution. It's only 15 to 30%. How do we message this effectiveness? On the one hand, that's grounds for hope, but we are concerned about things like therapeutic misconception, which is that, or preventive misperception. In other words, we know from studies of HIV, for instance, that people, when they initially got HIV vaccines, thought, well, now I have an HIV vaccine, I can go and expose myself to HIV because I got a vaccine. We now know, of course, that vaccines have not yet been effective for HIV, and that is not wise thinking. But we know with other treatments as well, for other diseases, people may feel after they have a treatment that is considered to be effective that they can now go back to taking care of dying villagers who may have excretions on them. If they themselves are only 15 to 30% covered, they could perhaps infect other people. So it's important that we have good social science, I would argue, to understand how are people seeing this, how do we best convey in people's own languages what this means. In COSA, for instance, I've done work in South Africa. COSA is spoken in large areas of South Africa. There's one word for cure. There's no word for experimental treatment that may not work, right? So if you say this is and you want to say experimental treatment that works in 15 to 30% of people and not more, the word that's used is cure. That's the word that's used, right? So if you say, think what that means now. If you say this is the fill in the blank for Ebola, people think, well, I have the cure, so everyone's going to want it. People are not going to be in other studies for other treatment, like serum transfusions that may in fact prove to be more effective in the long run. So I think understanding those issues is important. I would argue that not enough social science has been done to understand how people understand these issues. There was an article in the Times about a month ago that a major study that cost $50 million, mostly of U.S. taxpayer money, on HIV found that a lot of women in sub-Saharan Africa were saying they were taking the HIV medications, and when they checked the bottles, they'd empty out the pills and say, here's my empty bottle. Meanwhile, it turns out they thought that the medication would give you HIV, right? And so they weren't taking it, and the study was a waste. It was a lost opportunity. And I think the part of the problem is we didn't do enough good social science, anthropological, sociological research to find out how people understand the experimental interventions that we are offering. And I think that with Ebola as well, this is going to be very important. And this will inform decisions, I think, of how do we tell people about it when we have an experimental intervention? How do we respect their autonomy? How do we make sure that the risks are maximized and the harms are minimized? You don't want to say, here's a great treatment and it's great that we have something. And my guess is that other treatments may well be also only partially effective. And so as we get these things, I think there'll be challenges in how to convey these in a way that we're able to bring out the good aspect of them, prevent undue harm from people misunderstanding them. There are also questions who will get the vaccines or treatments as they become available. I think it was unfortunate when, in some ways, that when the first few doses of the first initial treatment, ZMapp, were available, they were given to Westerners. And there was, people were surprised that it even existed. And I think that points to partly the need for transparency. In other words, as I said earlier, what's ethical is not only the outcome of the decision, but the way the decisions are made. And it's important that these be very transparent processes of deciding once if there are better treatments that come along, who's going to get those treatments. If we still only have, let's say, 500 doses or 1,000 doses of a treatment or a vaccine, who's going to get those? Will it be the people in the Ministry of Health and his friends? Will it be, obviously, it should go to so-called first responders first, but beyond that, there'll be difficult questions. Lastly, I thought I would just say one of the other problems being highlighted as an ongoing and future issue is as we begin to have success with particular experimental interventions, there's a question, as I suggested, of what do we do with the other trials of other interventions that are ongoing. And it's been terrific that there have been industry funders as well as public funders who've stepped up, but that means The fact that there have been many funders means that they're not well coordinated. So at some point, it may make sense to say, look, you guys, you just started your treatment studies, and your treatment doesn't look like it's going to be as good as this one. Should you end the study? And again, these are very difficult decisions because, as we know from other experimental interventions in the past, initial studies may prove very promising, and later studies don't prove as promising. So again, we're dealing with these issues in the face of uncertainty and trying to do the right thing, trying to make sense of data which we only often have little bits of. And I think these are challenges as well. So I thought I'd stop there. And
before you go on, just a quick question about is there a forum that you're aware of in which some of these questions are not being answered so much as are the consensus? Is there consensus building for some of this, like what to do about research trials? Where does that get discussed, and how do the conclusions get promoted?
Yes, thank you. So, great question. So, I think this suggests the important role that academia has to play in this area, because there have been very important discussions and pieces that have been written in the Journal of the American Medical Association, the American Journal of Bioethics, New England Journal of Medicine, very high-profile forums that have had lots of discussion from the beginning of, for instance, initially, should you use a placebo? Versus, if we know that ZMapp has worked in, let's say, 2 out of 5 cases, is that enough of evidence to say, okay, we'll give ZMapp, or we'll have, and given the still limited number of doses, because it's made from tobacco leaves, should we have a smaller trial? Should we have a larger trial but use placebo? And a lot of these issues were discussed by academics who, at this point, have expertise that often underfunded state agencies may not have the privilege or have the benefit of having. So I think that there's not enough discourse about this. I think that academic journals have had a major role, in fostering debate, in which there have been, article written letters back and forth, and there's been a discussion of, Nature had some influential pieces early on, but there was a number of these issues being thought out in that arena. Unfortunately, I think the media played on fear to a large degree. As we know, there has not, as I understand it, there's not been a single American who has been infected in America with Ebola. You wouldn't know that looking at the press. Another issue, of course, is that the press responds to the concerns of Americans here, and I think it is unfortunate that it took the fear of Ebola landing on our shores, even if it only was in the case of 1 or 2 or 3 people, to motivate U.S. response, both in industry and by government, even though the epidemic was raging abroad. And I think that issue of whose risk do we care about? In other words, it's not, even though there's a risk to people in sub-Saharan Africa, it wasn't perceived as being our risk. We weren't perceived as risk at risk. When we felt we were at risk, suddenly it became a real risk. And I think those kinds of calculations really need to be rethought.
And ironically, we appropriated $5 billion actually in the aftermath of Ebola for Ebola. But Arturo.
All right. Thanks, Irwin and Bob. I appreciate your comments, and I really appreciate being here. It's really my pleasure. And as Irwin said, I'm at the New Jersey Department of Health, and no secret that we've been in the news quite a bit on the subject of Ebola, but we're talking more broadly than just about Ebola right now, but I'll go back to Ebola towards the end of my discussion. I thought it was really important because I did not understand this, as well as I do now, obviously after 3 years in this department, to understand the different levels of government and how they interact with each other. And there's some key federal agencies with Ebola and other infectious diseases that we work with closely. And then there's state and territorial agencies, and I'm at the New Jersey State Department of Health. And then we also work closely with local departments of health. So the key agency I want to talk about is Department of Health and Human Services, which is the government's principal agency for protecting the health of all Americans, and this is from their website, and providing essential human services, especially for those who are at least able to help themselves. And within Health and Human Services is the Centers for Disease Control and Prevention, and their role is obviously focused more broadly than it used to be, but it really, they're our main go-to, so to speak, as guidance on infectious diseases such as Ebola, and they have played a critical role in this. When it comes to state and territorial health departments, the most important thing to understand about that is that if you've seen one in this country, you've seen one. Each one is as different as the next. And that's really, really important. So when one is working with different state or territorial health governments, the health departments, one really needs to understand what's the structure. As an example, some include mental health services, some include Medicaid services within it. New Jersey does not. New York does. So that's just one classic example, but it's much broader than that. Local health departments are not necessarily as clearly defined, or even less clearly defined than state departments. Just as an example, New Jersey is one of the smallest states in the country. It's a very diverse and compact state. It has 21 counties, yet it has 90 local health departments. And they, different jurisdictions by municipalities and so on and so forth. In New York State, for the most part, there's one health department per county. Makes it some of the logistical working together. The role of state health departments, I'm going to categorize it this way. What is our role? Number one, over everything else, is to protect the public's health. And this is going to get to a key driver of some of the ethical issues that come up is, as you mentioned, Bob, the whole issue, we're still built on the principle of autonomy in this country, but we're talking about population health versus individual rights and individual health. Okay, not that we don't care about individual health, but as a state agency, we're concerned about the entire population. Within that overlying role, there are certain things that we must do and must do effectively. We provide grants and financial support to different agencies, including local health departments, but including non-government organizations, to provide services to the public. We also are responsible for preparing and planning for crises such as what has happened with Ebola, but we're always working on, generally potential public health crisis, with whether it's man-made or a natural disaster, and that is a responsibility that we have. We are responsible for educating the public, and we're going to talk about the media, I'm sure, because we are challenged with often communicating effectively with the media to make sure the right message goes out. So it's really about communication. I can tell you not a single day goes by in my job that I'm not asked to look at what we want to send out as talking points to the media on a matter of topics. I was just on the phone a few hours ago about a case of a child in New Jersey that you're not going to mention the details, that had an infectious disease problem, and how do we message this to the public to protect their health, because there's many concerns among the public that they may be at risk. And certainly with Ebola, we've been, it's just about every day we're doing something related to that. The other thing to understand is with the federal government and state government, there are these emergency support functions that they have developed. These are the way the government groups specific capabilities into an organizational structure to promote or to provide support, resources, program implementation, and services for those most likely needed services to affect the individual patients, populations, the environment, and so on and so forth. Emergency support function number 8 is the one that focuses on public health and medical services. And the department, the U.S. Department of Health and Human Services, that is the primary agency that oversees this. Okay, so that's also important to understand that. So in New Jersey, to understand the structure of our health department is one example, but to also understand the scope of what we deal with as we approach issues like Ebola. Within our department, we have 2 main branches. As Irwin mentioned, I'm in charge of the Public Health Services branch. Another deputy commissioner is in charge of the Health Facilities branch, which includes hospitals, long-term care facilities, and so on and so forth. It is mostly a licensing and regulatory function. On the Public Health Services side, there are 4 different divisions: Family Health Services, Division of HIV, STD, and TB, Epidemiology, Environmental and Occupational Health, and our Phillip Division, which is really a division on public health infrastructure, our state lab, and emergency preparedness. The challenges that we have is on the preparedness side. We often have to make convincing arguments about why we need resources from the federal government to be able to prepare adequately. Okay? So now, key drivers of the ethical issues around Ebola, but just about any other infectious disease that we have experienced as of late. Number one is what you already talked about, Bob, a little bit, is the population health versus the rights of individuals. And this goes to the quarantine orders. Quarantine orders are provided to individuals coming from one of the impacted West African nations that have individuals who have had exposure, mostly healthcare workers, but not exclusively, to individuals with Ebola, who are not yet symptomatic, and that's a sticking point here. These are people who are asymptomatic, but at any point during the 21-day incubation period from the last time they had contact with someone, they can become ill. And that's a key driver. What the issues we grapple with is that they're not sick, they look perfectly fine, but at any moment during those 21 days, based on the scientific information we have, they could become sick and put others around them at risk. The other thing is that Ebola is a great example, but it doesn't just apply to this. There is often less scientific information and knowledge that is a hard fact than we would like. So we have a lot of uncertain scientific information. You know, early on with Ebola, and again, we work closely with the CDC, who also doesn't necessarily have this information because not necessarily enough research has been done on this, whether it's the use of vaccines or the use of treatment medications that were, that we know that ZMapp was used as allowed in a compassionate care manner to individuals, mostly Westerners, who had Ebola, but there were no human studies done yet on that. So you have to weigh, that uncertainty of, are you putting yourself more at risk by taking this medication without knowing what the consequences might be, or not. Then incubation periods and infectious or contagiousness periods is also something that we have to work a lot to really understand. With Ebola, we actually have a good understanding of that, a reasonable understanding because of all the number of outbreaks that have happened over the years. But with other infectious diseases, it's not always so clear. And certainly that's an important part of our messaging and communicating to the public to make sure that they understand what is known and what is not known. Costs, financial costs, we have to grapple with. How much energy and resources do we put into the preparatory part of an infectious disease outbreak? And when we do need the response, if we didn't do that preparation we're not ready. But if you put too much energy into that, you may never need the response. So just something we think about. And lastly is priority populations. When a treatment becomes available, who gets it? Are there healthcare workers that would be, in the front line, so to speak? Should they be the first ones to get a vaccine if it becomes available? And this is something with smallpox, if you recall, I think it's been 15 years or so since this came up, or maybe less, but 10 to 15 years ago, where who should get the vaccine became available when we were concerned about a release and a bioterrorism attack of smallpox. So to go to the case study we're talking about here, the Ebola virus disease or Ebola, some of the specifics that we have been challenged with is, for starters, personal protective equipment at the level that you need for Ebola was not readily available. So last year, had we had an issue and we were concerned that there was going to be widespread, and so far, by the way, just so you know, because in New Jersey's on the paper, we have not had one single case of Ebola in New Jersey, right? Sometimes I wake up at night and say, how many cases we had? None. But we spend a lot of energy on trying to assure that doesn't happen. But if we had 10, 20, 100 cases, we may have not had enough personal protective equipment available to that level. So how do you make a decision about which hospitals get it and how, and who gets it in the hospital when they do need it? Cost of the quarantines. The quarantines do cost money. They cost money to the federal, state, and local governments. So you have to weigh that against, how many people we're going to hold for 21 days to make sure they don't get, they don't become infectious and turn to risk the public in general. Then the other issue is separation from family and loved ones. We've grappled with issues such as if we have a child who comes with a parent who is now going to be quarantined, but that child is not at risk for Ebola, but if they stay with a parent, they will be. What do you do about that? Illness onset versus contagiousness, I talked about already, but in those 21 days at any moment, if someone is not quarantined and they're out in the public and they become sick, then how do you deal with evaluating who that person may have put at risk versus being quarantined? The emotional duress of healthcare workers. I think I'm finally starting to see some of this in the media, but in my conversations with different healthcare workers who are coming from West Africa, my biggest concern that we must deal with is the duress that they're coming with already, having been in a place with this epidemic, where Ebola's epidemic, they are seeing people die, and particularly, people that as prepared as some of these are, having done international work, many have not. So we need to make sure that they are supported in that way, at what cost, and who's going to provide it, and how do we identify that early on. And then disclosure of information to the public. Again, it's about effective communication at the right time. Sometimes the media gets ahead of us and reports information, sometimes correctly, sometimes not. And then we have to backtrack and try to do some damage control with that. So you mentioned about the three major areas where ethical issues come up with Ebola virus disease. The policy, which of course involves government, but it's not just government. It involves also our getting information, not only from the CDC, I should also mention academia, because we do work closely in government with academic centers to understand what the latest scientific information is. Clinical care and research. And again, when it comes to clinical care, it's that balance between that and population health. And in research, the challenge with research is often the research lags behind practical matters and real-time events that are happening. So with that, Irwin, I think I'll leave it there because I know we want to leave time for discussion, but I appreciate, again, being here, and I don't know if you want to take a question.
Yeah, let's go to Jeff.
Okay, thank you.
I just have one slide I'm going to put up to give you an alternative instead of looking at me. This one. Great.
Jeff, if you go down to the bottom, on the right, all the way to the bottom.
All right.
The little bit.
Oh, what did I do? I already screwed up. Okay, great. All right. Well, thanks everyone for making it out. Thank you to the Earth Institute for sponsoring this event, and to everyone on the panel for the privilege of being on this with you. So, I keep thinking back to this argument I had with one of my professors in my MPH program about it was about HIV/AIDS and harm reduction and things like that. And the whole time and I have nothing but the utmost respect for this person. So if you ever track down whoever it is, or if he watches the video or anything, but it was a really it was a very important argument in my own development, because it was it got to the point where I think the argument was being made to essentially be a soldier of science, that if the data says this is effective, that's what you have to advocate for. And what I was having trouble with was that this was existing within a community that had different values. And could it actually be implemented realistically? And what was the community compromising in terms of its identity to do this? And so it was very, I think, important debate, not just because I was part of it, but because it really kind of brought to light this conflict where we even when we have perfect data, even when we have really good science, it has to go out there and be effective in a world that may not value it to the same level as other factors of their identity. So I thought I would talk a little bit about some of the different theories of scarce resources and distributive justice, and then kind of talk about some of the examples of Ebola just to kind of illustrate these. And just as I talk through it, I'm not passing judgment on any decisions that were made in the response and things like that. It's really just more of an exercise to better understand the context that these different theories kind of come into conflict. So for major angles for looking at these ethical problems. So utilitarian is really about the greater good and public utility. This can be a very cold-hearted approach. This is the where if it's for the greater good to take somebody off of the ventilator to give it to somebody else. This is where those kinds of decisions are very, very hard in the data. Although there's a lot of variations within each of these and a lot of overlap between them too. So I don't mean to oversimplify in my oversimplification. Libertarian is really more about fair processes and less intervention on the government side of doing things. And it's really about just making sure everybody has a fair opportunity and then allow them to make decisions within that. Communitarian creates the basis where there is no single sort of foundational ethical test, but those are developed as part of the evolving experience of the community or of the group that you're looking at, and so those values come from there. And then egalitarian, about equal access, or at least equal access to the minimum necessary services. And then in talking about scarce resource allocation, there's kind of two altitudes. There's macro allocation, which is how do we set up the systems of allocating resources, and then kind of the individual decisions. So let me ask right off the bat, because this was a question that I found in a more let's say a less scientific publication. Is it ethical to make a profit off of Ebola response? Who would agree that it's ethical to make a profit off of Ebola response? Okay, who would disagree? Okay, well, the good news is you're all wrong. There's no right answers in ethics, right? So, or maybe you're all right. Okay. I'll say you're all wrong. It's more job security. Anyway, so I think I thought that was a really interesting question because looking at kind of these different theories and sort of the structures that we set up for how we respond to these rare events, most of our capacity for developing pharmaceutical interventions exists in the for-profit pharmaceutical sector, right? We have these large multinational corporations that have the factories, they have the chicken eggs for growing stuff in. So there's a tremendous influence of kind of the free market perspective, right? Of creating competition and using market signals to influence decisions on what's invested in to produce. The downside to that is that you have, it becomes very much a numbers game, right? Ebola hasn't impacted as many people relative to erectile dysfunction, right? Although one would argue the consequences of Ebola are probably much more severe and more deserving of a significant investment. So that's where kind of the government approach comes in to try and equalize that. Right, government looks at regulating the market. In some ways, it's for safety and things like that. But then that has influences by increasing the cost of production. There are strategic investments made. In fact, most of the pharmaceutical interventions for Ebola that we heard about and are still hearing about had their seed money from DoD funds, NIH funds, CDC funds, but from various pools of money that were meant to essentially start the pipeline of drug development in the event that it needed to be brought up to scale for mass development, but probably didn't have enough money in their budgets to actually fund massive development. So there's some investment in sort of the greater good coming from there that one could argue that the market signals alone wouldn't be sufficient to make. But then the budgets for the organizations that are funding this research ultimately come from an appropriations committee in the Congress and the Senate with elected officials from their own districts who bring their own community values. And so we see this a lot, particularly in reproductive health, right? You can teach sexual education, but then not teach about the use of contraceptives. So there are these kind of community-based values that aren't really based in the science, but are based in religious beliefs or cultural beliefs and things like that influence this. And then, finally looking at that equal access, right? So we have mechanisms like Medicaid and welfare that are designed to kind of create a minimum level of access. But then when you bring this on a global scale, you then have the competition between, you have organizations like the WHO, which are, theoretically trying to provide equal access globally, but they're funded by individual nation states. And so when the recession hit globally, there was a choice that had to be made as to what level these nation states were going to continue to fund WHO. And in that loss of funding, WHO had to make decisions on what its response capacity would be versus its scientific capacity. And in the much of their response capacity was lost while they still sort of maintained an ability to be a ground for sharing genomic information and other experimental information and a clearinghouse for some of that. So when it comes back to that question to make a profit off of the Ebola response, the system as it's structured right now, in a sense, requires that because that's the incentive to scale up. And in some cases, those buyers can be the general public. In some cases, they can be governments. But to a certain extent, the system doesn't work without having profiteering for these emergency events. And again, it's not to pass judgment on for better or for worse, but it's just a large part of the landscape where we have the interplay of all of these different values going into the development of the structure that lays the landscape that these diseases emerge within. And they're oftentimes in significant conflict with each other. And that's why, so many things really have to be done on a committee basis and a consensus basis to try to work through that. So the other piece I want to look at is the micro allocation level, and that's really, there's one case in particular, and it's been referenced by my colleagues here too, is the initial use of ZMAP and the initial use of ZMAP with the Westerners. So they actually weren't the first ones to be considered for the use of ZMAP. That there was actually the chief physician of the LASA program of a Sierra Leonean hospital, Dr. Sheikh Humar Khan, became sick with Ebola, and it went to an international committee that actually debated the ethics of whether or not he should have access. There was one course, 3 doses of ZMAP in the region, and it actually wasn't brought there to treat anybody. The person who brought it over had it in a freezer to test its ability to stay viable in a tropical, humid environment with intermittent access to electricity. And so the ethics committee took 3 days to debate whether or not it should be used, and ultimately decided it would be too risky to use. Dr. Khan eventually died of Ebola. And just as an aside, 3 days is really a long time to be deliberating something when you have Ebola. And this is something we see, I'm off topic here, I promise I'll come right back. In disaster response and decision making, not making a decision is the same thing as deciding not to, only you don't have the ownership over it. And so I think that, you know, one, it's a testament to how complicated these ethical considerations are. There are no easy answers, but I think it's also important to keep in mind that 3 days is a long time. So anyway, so then came the first U.S. cases, Dr. Kent Brantley and Nancy Wrightball. So they went a different route. They didn't go through the international committee. They went through the representative from the CDC, the Canadian government, and kind of took a more sort of direct route and ultimately had it released and flown over. And then, so this created some very interesting ethical questions. On the one hand, it was, you know, brought over there to test under one set of circumstances under the development timeline. You know, is it viable? Or can you set up logistical? What do you need to know to set up the logistics for distributing it in Africa? And so removing it from that potentially removes some important data for setting that up. The other thing is that both of these individuals had been provided with other treatments. They had been provided, you know, serums, transfusions. So there's a lot of noise in that too. So there's really no usable data from one person taking this dose with so many other variables brought into this. The other thing is they actually, one course is 3 treatments, they split it between the 2 of them, so neither of them had the full course of treatment. So it really came down to a very communitarian decision being made by the groups who were closest to, you know, where they came from that won out, which is, you know, FDA approval of compassionate use access, and that, you know, we'd rather give it a try and rather try to do something rather than nothing. But some of the other arguments that would have come through that in terms of letting the development process go through to create open access, the use of the data for public utility ultimately weren't reconcilable, but the decision that came out was to use it. And again, it's not really for me to question whether that decision was right or wrong, other than it happened, and that the landscape really comes from so many different angles that more often than not, science in and of itself isn't enough to get to the finish line and to make these decisions, and particularly in an international environment where there are so many other competing factors related to that. But I think on that note, I'll
Great. Thanks, Jeff. Very, very good, and thanks to all of the panel. And before we open up to all of you, I'd like to just see if there's any questions among the panelists. And Bob, do you have anything you wanted to?
Okay.
No? Okay. Arturo, I wanted to ask you something. What is the process in government? I guess your state in particular, since you said everybody's different. But when you were dealing with limited financial resources, what is the process for prioritizing when it comes to deciding how you're going to spend what's going to always be limited resources on a variety of public health needs? Does it come down to the decision of an individual person? Are there wrenching discussions among a number of people and different participants? How does that work?
Yeah, that's a really good question, Irwin. So and I think most state governments would function this way.
that the decisions are brought up the organizational chart, and for me is I would work with the programs. So in this case, it'd be our infectious disease folks in epidemiology, environmental and occupational health, and our preparedness folks.
Yeah.
We would discuss it, bring it to the health commissioner, and then the health commissioner or her equivalent across the country reports directly to their governor, and they would bring it up to the governor through their office to say this is what we're talking about, big sums of money to make decisions one versus the other. That's the process for doing that. So it has to go through the governor's office, and then they have to weigh that against other priorities in other state agencies. So understanding the health department is one, I think, of 17 different state agencies in New Jersey, and it's probably more or less the same around the country. So that's the process. It goes up the chain. Health commissioner has a discussion with the governor's office, and or the governor himself in this case to make those decisions.
It's very interesting. Just to note for people, this is also what happens on a national basis or in any governmental situation where the discussion may happen among the scientists and the people that are dealing directly with the challenge, but it ends up being in the political arena where the final decisions and priorities are made, for better or for worse. That's
yeah. And one other thing I should add, then we also, across health departments around the country, work closely, and this is why I thought it was important to mention Health and Human Services and the CDC. We work closely with them and help them make some decisions of where the priorities lie based on different state needs. It's not as simple as it may seem. You have infectious disease, this is where the money should go, and there are debates and discussions that are lengthy, and sometimes, often, unfortunately, Jeff, like you said, too laborious and not very timely to come to those decisions. As an example, Health and Human Services has come through, and they have to go, through the president, executive order, get some financial resources to deal with Ebola, and that is happening right now as we speak, and some grants have come through to help the states do that. But think about this. This process started last summer, I would say, and now it's where we're getting to the money, and then there's debates in the federal government. Can some of this be used retroactively, or is it all proactively? And I will say the majority is proactive. You can't go back on the majority of cases with these dollars to get reimbursed for services you've already provided. So therefore, that comes usually out of the state budget. So
interesting. And for you, Jeff, just a quick question. There's the issue of what the pharmas work on in terms of pharmaceutical development, R&D, research and development. That decision is really driven by business considerations in the pharma industry, which may or may not be consistent with what the larger public is. So now we're talking about the public good versus the corporate good, as opposed to the public good versus the individual autonomy issues. Right. How does that get resolved when the pharmaceutical industry says, we're not going to invest in an Ebola drug right now because we don't see a profit from that, or we're not going to invest in new antibiotic development to deal with the antibiotic-resistant organisms which are sprouting up dangerously, so to speak. If there's no business model, how does the public good manifest itself? And what's the consequence of however it does or doesn't?
No, that's thanks for the question. There's a couple of different ways, but I think the primary method that's resolved is through some degree of government intervention. So one example is the CDC's orphan drug program that essentially subsidizes certain drugs to keep the factories open so that they're available where there's no viable business model for keeping them available, but that we're able to retain a certain amount of them for the small number of people who require them. At the other extreme on the purchasing side would be the strategic national stockpile. So a lot of the countermeasures for bioterrorism events. Fortunately, bioterrorism events are very rare, and to date, relatively low intensity in terms of the number of people impacted. But obviously, some of the nightmare scenarios are very dramatic, and so there's a very significant program through the Health and Human Services that essentially purchase these drugs for a stockpile maintained by the CDC to be able to be released during that. But then there are grades in between, and I think one of the challenges in a post-9/11 world that the pharmaceutical industry and government have had trouble reconciling is creating more nuanced public-private partnerships that can, create a private incentive to go into the development of this without a level of risk that is too great for them to essentially make the case for. I know it's been one of the sticking points in sort of further development of pharmaceuticals. It's actually the availability of funding to develop next generation pharmaceuticals and vaccines originally didn't have a lot of takers among the big pharmaceutical companies. So what it's led to is the creation of a lot of smaller companies that are willing to take the risk, and some of them have gone out of business as a result of it. When the larger pharmaceutical companies have declined to be involved because the risk was too great or the liability was too great.
Yeah.
So liability is another factor we could spend a lot of time talking about, but that is as important as the economic return is the potential risk of liability if something goes wrong.
Big questions.
Yeah.
Okay, your turn. Who would like to weigh in or ask a question? Now would be a good time. Don't be shy.
I'm going to have to run.
Yeah, go ahead. Yeah.
Thank you all.
Dr. Klitzman's going to have to run, but
So I understand that a short-term political consideration may have distorted some of the decisions that had to be made, but it still makes me wonder whether some of these difficult questions that come up, would you really want the informed, benevolent dictator to make these decisions alone? It's not obvious to me.
well, it's certainly not obvious to me either. But and I think what we're dealing with are very complex problems, no clear answers, and a lot of competing needs. What do you think? I mean, give him back the microphone. I'm not letting him off the hook. If you could just, what's the answer to your own question?
Well, just to be more specific, I understand that at least in one of the Western African countries, a cordon sanitaire was imposed with army shooting some people to prevent them, or at least preventing them from crossing that. How can these decisions be made if you don't essentially forget about political considerations if there is some election coming up?
Well, I'll tell you one thing. I in the book that Peter mentioned that I wrote, I had some long conversations with pharmaceutical company CEOs, and one of them suggested that, at least in the United States, that we are missing a public health czar. That somebody who could be a final arbiter of these kind of very complex decisions and could lay out an agenda for what the country needs. It's not the Surgeon General, it's not really the Secretary of Health and Human Services, and we don't really have a mechanism for setting the parameters and the agenda for the public health needs and how they should be addressed. And I think that's a problem because the absence of that leaves it open to random decisions or decisions based on, the individual needs or local communities and other things which don't necessarily have a basis in fact or science and don't necessarily serve the larger public good. So I don't know the answer, but if either of you would like to weigh in, please.
I'd like to weigh in on actually what keeps coming up as political agendas and the timing of elections and all that. And I think it's really important to say something. We have to be cautious about how the media wants to drive things versus what really exists. And the policy for quarantining individuals who are coming from West Africa is the majority of states have the same or nearly the same policy. But it's interesting how only the media was only focused on a few states. And I think you can make of it what you will, what the reason for that is. But one of the reasons is, understanding is that 95% of the individuals coming from those West African countries flew in through 5 different airports. And 2 of those airports were in our area, JFK and Newark Liberty International Airport. So that's part of that drive. It just may have coincided with what was going on during political elections. So we have to be very cautious of that. But that notwithstanding, you could, it would be hard to separate it out. I can tell you, and I can only speak specifically about New Jersey, even though I'm hesitant to do too much of that because this is broader than that. But we do grapple internally with all of these issues, and from my perspective, it really did and does come down to protecting the public and making the most informed decision, okay, based on what we know. And that's where we're at. Because can you imagine the policy isn't to quarantine somebody. Now somebody's out in the community and they become ill. You don't have to imagine it. But they become ill and come in and wait too long to come to get medical care, and now they've exposed others. We would be having a different argument if most states didn't have this policy, and now we have and kind of what happened in Texas. We have an outbreak. So it's weighing both. Is that political, or is that just a sensible thing to do, that you're restricting the movement of a small number of individuals to protect the larger population? So.
And I would just add, too, that a lot of this plays into, like I said, that macro allocation strategy. So with pandemic influenza, there was a strategic investment made to conduct pandemic influenza planning back in 2005 with the bird flu, H5N1. And part of that process was actually coming up with protocols for the scarce allocation of vaccine as it became available. And then in 2009 with H1N1, there actually was a blueprint to work from for doing this. So that consensus was achieved outside of an acute event when there was time to argue about it. And I would venture to guess that if a viable vaccine had become available for Ebola and there was a domestic response, that blueprint probably would have served as a good starting point to sort of reduce the timeline for kind of going through that decision-making process. So when we talk about scarce resource allocation in the acute event, you're really out of options and you're just dealing with the factors at play, what you have, how much time you have to make, and what to do with it. But the strategic allocation is a larger sort of value judgment on how much we're willing to invest, but also take away from other programs to give us more options when the acute events occur.
Tough. Yep. Yes, sir.
My question really follows on. I was here at the Earth Institute last autumn, be here again this coming autumn, so saw the hysteria, if you like, in New York. I'm currently at the University of Cape Town, and at the mining indaba we had last month, the various mining companies operating in Guinea, in Sierra Leone, and in Liberia all pointed out that in their areas there were no Ebola cases because they set up a very clear cordon sanitaire. If you moved out of that area, you got sacked. Nobody was allowed to come in. Food was being very carefully assessed, and nobody died. And they saw, if you like, that the private sector taking a very strong role in public health was a message which was important, that people who are looking at the Ebola crisis, looking back, to actually reflect on. And that the disaster was really one of the state sector, the non-private sector, not taking a grip within those countries, and that we should be very clear that if it happens again, we must have almost an equivalent of martial law, military law, to stop it, because it was not. It was an unnecessary epidemic.
Jeff, why don't you answer that?
Yeah, no, and I think that's a great point. And, the private sector is getting a lot better at understanding the cost benefit of responding versus staying away and saying it's a government problem. And in fact, in a lot of MBA programs now, you're seeing actually sustainability as part of the cost benefit analysis and actually being part of that strategic investment and valuation of running an organization. And I think that's critically important because it does two things. One, it decreases the area or the scope that the public sector has to deal with. When the private sector is able to kind of take care of their own interests in a meaningful way, and there were other examples in the last series. I talked about the Firestone plant in Liberia that essentially removed, I think, 80,000 people from the government's group they needed to worry about by treating the employees and the families. So I think the more that these best practices and these lessons learned can be shared, and the more that the private sector continues to embrace the bottom line value as well as the ultimate sustainability value of this, that the more partners we have in responding to these kinds of crises early and effectively.
Yes, there was a question right there.
Yes. I'm concerned about the incubation period I'm also concerned about when it started, why it started, about the bats. I'm concerned about the burials. I understand some of the undertakers have come down with Ebola. And I also read someplace that they were taking the bodies, I believe, from Sierra Leone, someplace, Guinea maybe, out and burying them. And I'm concerned that years from now, you know, in a common grave, that they may decide to build an apartment building there. And if they're that frightened about the dead bodies, how do we know this isn't incubating? Or I'm just concerned. And during the lull now, I wonder if there's any research going on. Just, you know, it just, to me, it just came out of nowhere, and it was very frightening.
In terms of the incubation period for Ebola, that is about as clear as anything that we know about Ebola. In terms of after post-mortem, you know, what the risks are to others, the current understanding is that there, you know, after a few hours or at least a day, that there's really not much of a risk. But research would have to be done over time. And I don't know if anyone's doing research in that area specifically. I don't know, maybe Irwin or Jeff do. But I think that one of the issues we have here is if we do have someone pass away from Ebola, what do we do with the remains? And even though we are pretty certain that there would be no risk to anyone if they are cremated and incinerated and the remains are placed somewhere, those concerns do arise or have arisen even here. So as far as the science goes, what we know is that there would be no risk there, but you know, 20 years from now we may. So I think concerns are legitimate. I don't know if there any research going on in that area because I'm not sure that's the priority with the research. I think most of the research is going into treatment, right? And so.
I would also add that there have been, as Bob Klitzman mentioned before, there have been recurrent episodes or outbreaks of Ebola since the 1970s is when it was first discovered. So what happens is you never totally eradicate the viruses, and the viruses may mutate, but basically the virus can be harbored in a bat or other species, and then outbreaks occur at some frequency that you have difficulty controlling. So what you have to have in place are processes to keep it as soon as it's rapidly identified, first of all, and then contained once it is identified, and that's the way to deal with that. But it's part of the many challenges in dealing with a endemic situation such as Ebola right now. Yes.
Hi, my question is for Dr. Brito. I wanted to follow up a little bit on that question of the ethics of political gain during a crisis like we have last year, and more specifically about the handling of the quarantine of Nurse Hickox. Some may say that she was put under unnecessary hardship since the moment she arrived to Newark, and it ended up being a communications disaster for the governor. Could you share with us any lessons learned?
I think what I can say, and I do have to stay away from specific examples, but I will say in general, what the media describes is not always all the facts or even the correct facts. So there's a lot more involved because we are concerned also about individual rights to privacy. So when you think about it, you have an individual who becomes a patient, so we're not privy to describe all the details. I think that's all I can say about that example. But in general, I think the challenge that we have in government is exactly what you said, is communications. Effectively, and again, the media sometimes gets ahead of us on that before we have all the facts at hand.
Arturo, do I have the same restrictions just by
Nope.
approximation? Okay, fine. So let me address the question.
And I may
There's
respond
a
to
wall
what you
here.
say.
Yeah, okay. I think there's no question that political considerations are always at play. Republicans, Democrats, Tea Partiers, and progressives all have a message, and will look to opportunities to express that message. And interestingly, when this situation sort of was at its peak with Governor Christie, he was joined by Governor Cuomo in a press conference one Friday night to talk about new policies, at least in the case of Governor Cuomo in our state, that he introduced without actually even speaking with Mayor de Blasio, with whom he had been speaking hourly for days prior to that, and then suddenly appeared at the press conference with Governor Christie, and the two of them announced these more or less draconian, but certainly press-noted comments and policy declarations. So you have one governor who is in the presidential race, and another governor who dreams about a presidential race. And, there's desire to look like you're making decisions and you can step forward and you're being assertive and you're meeting the public expectations about what should be done and you're responding to public anxieties. And there's no denying that there's politics. And in this case, it wasn't just regular politics. This was presidential politics at a high level. And I think both of them, both the Republican guy and the Democratic guy, made a bad mistake because they were coming up against absolutely clear scientific evidence that suggested that the policy recommendations we're making were just fundamentally incorrect. I think there's probably a lot of details. And I think, as Arturo said, in fairness, there is very, very much that the media gets wrong all of the time, and interpretations that go beyond the facts and so forth. And I think that's all reasonable, but I don't think there's any question that politics were involved in some of those decisions.
So, two things. One is that the majority of states have the same or nearly the same policy. Okay, that's one. The second one is, think about this, because this is discussions I've had with other healthcare workers who have come from West African nations. You have just spent 2-3 months working in a very challenging environment in West Africa, dealing with death in front of you, okay? Now you take a flight through Europe, connect on that flight, and the next day you appear in this country. Imagine your emotional state when you get here. Think about it. If anyone, I'm sure most people here have flown internationally or at least once in their life, how tired you are just from going to Europe and coming back, right? Now you've worked there for 2 or 3 months. You fly to Europe for overnight, come here. Think about your emotional state and how you may interpret or misinterpret what the policy is where you're arriving and how that might be portrayed by the media. So just think about that point of view. So I think, again, one thing I've learned, what you read in the papers, and I have a clear example from this week that's not Ebola related, that what the media says is completely inaccurate, and then it comes back to government. Why is this the case? And we have to correct that that's not the case. And rarely do you get a announcement in the media, an apology for incorrectly, portraying something. So I'm just saying that there's a lot more details to each and every case, and it's a case-by-case basis. Again, the majority of the states have the same policy, but we are in the limelight in this part of the country. Even if there weren't presidential aspirations on one particular governor here, that is still theoretical, but we are in a part of the country that gets a lot of media attention, New York City itself and the areas around it. So I think it's going to be, sometimes not exactly accurate.
Fair points. Yep. Anybody else? Yes, ma'am.
Given the seeming regularity of Ebola outbreaks and the potential of ZMapp, has pharma moved forward with its production?
Yeah, there's actually So ZMapp, I believe, is the one that's grown in the tobacco leaves.
Yep.
And that was when it ran out of the small kind of experimental doses, it actually went into mass production. And there's also significant investment in many of the companies that have produced these, which were relatively small companies for doing this. So that's where kind of the free market kind of private sector incentivization comes in, as well as the kind of government seed money. I think the challenge is that you have to wait for stuff to grow. It takes a while. And so a lot of the large amounts of doses are, initial vaccines are just now becoming available for doing that. But it looks like for the next round of outbreaks, there will be an industry that's much more poised than it was for this one to respond. In this response, they were actually better poised to respond than in previous ones because of that seed money that was issued through some of those various government sources to incentivize some risk-taking in the research and development realm. I think another important point is that we got, stopping the outbreak also wasn't limited to the availability of pharmaceutical interventions, although they'll be extremely important for saving lives and preventing it in the future. There wasn't anything categorically different about this outbreak in terms of the nature of the virus and the way that it spread. And there were a lot of very nuanced arguments that I think were good ones to happen in an academic forum about, whether it had the potential to be airborne and things like that. But at the end of the day, it spread just like it did in any other outbreak, and that the primary barriers to stopping the spread were geography, it emerging in very urban areas instead of rural areas, and political, where there was a very large denial. And actually, back to the example of the private sector, is that there were private sector responses underway in the affected areas, while some of the governments were still arguing whether or not it was real or a ploy to get more funding.
Yes, actually, that issue of denial is very interesting. And the first time I went to Ethiopia a long time ago, it was right after during the famine in the late 1980s, mid-1980s. There was a cholera outbreak in Ethiopia, and the government was really, really interested in suppressing that information for a variety of reasons, having to do with a lot of factors like not wanting to discourage foreign workers or assets coming to the country and other issues. But that was really a problem, and the U.S. CDC actually, through clandestine means, actually smuggled into Ethiopia some cholera testing kits so that it could be verified what the extent of the epidemic was or outbreak was and where it was. But there are a lot of very kind of strange analyses and decisions made by government that sometimes are difficult to understand but are certainly present. Anybody else? Yep.
Shall I have a quick second go?
Of course.
Hans Rosling, the Swedish epidemiologist, spoke last Thursday at a UNICEF meeting about the lessons to learn from the Ebola outbreak. He worked in Liberia at the height of the epidemic. His concern was the exaggeration of the number of cases by people outside West Africa, and begged that what should happen going forward, which is completely the opposite of what you just said about Ethiopia, that we should take the figures that are registered by the Ministry of Health in each country as to the number of cases that there are, rather than what he thought were very wild assertions of significantly higher number of cases that was put out to the media by a large number of people who shouldn't have done it. Perhaps the panel like to have a think about it, whether you've heard of Hans Rosling. He runs an organization called, I think, gapfinder.org, but about how the media misleads much of the world about what's actually happening on issues of health. But in this case, he was actually there on the spot between September and January this year in Liberia in the Ministry of Health. So transparency is a difficult one, and was the number of cases, do we think, grossly exaggerated, only to actually come down very rapidly in the last 4 weeks when the two numbers came together?
Well, it's a really interesting point, and reflects a very complex situation of who wants what to be out there. I would say, in defense of the exaggerators, that there was always this sense that the counting was very difficult. So there was an extrapolation being made based on what you could actually see versus probably what was out there. In other words, assuming there's some underreporting. So putting all these factors together, I don't know what the truth was, but I just want to tell you something else from my that first trip to Ethiopia that I think was it stayed with me obviously forever. But here's what happened. So I was with a group from USA for Africa, the We Are the World people. So it was Harry Belafonte and a few other people and myself, another doctor, and we were taken out to these sort of high-level demonstrations of what was going on during the famine. So one morning we left Addis Ababa, and we were told we were being flown out to a village that was in extreme duress from famine. And what we're going to observe was the Royal Air Force, the UK Air Force, was going to be flying over a field by the village and dropping these 50-pound or 100-pound sacks of seed or grain, right? And we're going to watch it, and they were designed, we were told in the briefing, to hit the ground, break open so that nobody could take the entire sack, and the people would come scoop up what they had. And we landed at the village, and there was one Ethiopian soldier who was probably around what my age is now, with probably a World War I carbine, and he was standing at the periphery of the field, and there were villagers who were all waiting. They had scoops and this and that. The plane comes in, as we were told, drops the sacks break open. Now, we had press with us, but because of the constraints about flying, they had what was called a press pooled photographer. So ABC, NBC, and CBS, that's more or less what there was at that point, shared one of their photographers who would take all the film. So they were all operating from the same film, and then they would cut their own stories, the three major networks, individually. So the thing happened, we watched it, it broke open like they said, there was some scuffling around where the seed was being picked up by the scoopers. The guy waddles out with his carbine and kind of tries to break it up a little bit so that people are not fighting with each other. The thing is completed, the grain is all picked up, we leave. A couple days later, we're in Nairobi at the center where the TV news stories were cut by the three networks and then sent back to New York. And the guy says to us, would you like to see the three TV reports on this episode? I said, sure. So we're sitting there and watched three entirely different stories about the thing that we had watched that had been filmed by a single photographer. So one story was more or less accurate about the RAF planning. Another one was on the defective bags that broke open on hitting the ground. Our hair was standing on them. Because we were all told, including the journalists, that this is what was supposed to happen. And the third one had to do with the army of Ethiopian army interfering with people picking up the grain. I'm telling you this because this wasn't just like a written, printed news story where you could say, well, so they're interpreting it differently. This is something that we had all watched with our eyes and heard the briefing, yet here's three different interpretations. And I'm mentioning that here because we really don't know the veracity of everything that we read or even see.
There in the department for those 5 months.
What's that?
Hans Rosley was in the
that's what I'm saying. So this is
Monrovia.
Right. So I don't know what the conclusion of that is, but it just kind of makes us want to be a little bit skeptical about what we're seeing and hearing. But I would like to get Arturo's take on that because that's a reality, and that's more or less what you're saying.
Yeah, and I think we have to remember, the media is in the business of selling news, and they're going to take the angle that's going to sell the news, first of all. But then they also have to think about why there may be exaggerations in this case. I'm thinking back to the earthquake in Haiti, where their government was saying it was 230,000 individuals that died in that earthquake, but then other reports were saying it was a lot less. Well, if you're the government, and I'm not saying which is the accurate one, but if you're that Ministry of Health or the government, You want it to be a larger number because more resources are likely to come in, and that's what's going to sell. So it has to do with, I think maybe the best thing to say is that when we read the media, we have the responsibility of, looking at it carefully, reading between the lines, but also of making sure that others understand the science behind it. And I think that's where, we don't have a world, and certainly a country, that has a high science literacy level. And, to even explain population health versus individual health is a challenge, right? And we all struggle with that. But we do have that responsibility to be careful how we read the media, interpret it, or see the media in this case. But just remember, they're in the business of selling the news, and sometimes, I'm not saying everything they do is inaccurate, and sometimes they do a great job of bringing to the attention of others what real needs are, but sometimes it can be embellished or inaccurate, or a reporter who doesn't really understand the science behind it may inadvertently, but not purposely, print something that is inaccurate.
Did you have another question? Back behind you, right?
Hi, this might be a bit of too general of a question, but on the topic of being transparent and how we talked about the ethical issues in collaboration, I wanted to ask, do you know of, or are there any pursuits in creating institutions that foster collaboration within the international sphere, I guess, whether that be between the CDC and maybe the Ministry of Health in another country? Are there efforts to kind of create this sphere where people can actually discuss the different views that are being brought about? For your example, in Ethiopia, I'm from Ethiopia, and I know my parents grew up during that famine time, and so I think it's really interesting that you had that experience. But are there spheres or opportunities for people to talk about these things and kind of move forward from that?
Well, that experience, it happened to be in Ethiopia, but it could have been anywhere, and it is everywhere, and it is not just in the 80s; it's in the right now. So it's. I was just telling you that as an example, but it's not at all uncommon, as Arturo is referring to. It's just the way it is. But in terms of discussions and interactions between and among people concerned about public health, that happens in a variety of ways. It's theoretically happening on a high level at the World Health Organization, although plenty of issues there. But last week, for example, Tom Frieden, the U.S. Centers for Disease Control and Prevention head, was in West Africa, and there was a constant level of communication among many foreign health departments and the Western African countries that were affected. So, and I think there's pretty much an acceptance of that dialogue needing to happen internationally when there's a threat to the international community, or even a severe threat in one particular country. And so I think that's not out of the question. When I can't remember that I mentioned this about Katrina, when we had an offer from Cuba to have a bunch of docs come here, but there were many offers that came from the international community to come and help out here. UK government, actually, right? So exactly. So there are all sorts of opportunities like that, but. Yeah, good. It's a good point. I'm glad you asked that.
I would just add to that, really over the last 10 years, technology, and particularly mobile technology, is really kind of democratizing the sharing of information as well, too, which has its pluses and its minuses. But we're, seeing areas that really take a lot of effort to close off what's going on, and still information getting out there, whether it's through social media or through videos captured on a phone or things like that. So it really is kind of creating a bit of a game changer in terms of that. Organizations like WHO are designed to be these international forums for sharing, but they still rely on the member states that fund it, support it, vote on it to then be willing to air their dirty laundry on that stage that they do it. And one of the most important things that has come out of it in the last several years with the international health regulations really requiring countries to report diseases that have impact of affecting their neighbors also still isn't fully ratified by all of their members is hitting a lot of inertia with doing that, because in principle I think everyone, like, I want to hear your stuff, but I don't necessarily want to share mine, and so it's difficult to break away from that without, but as I mentioned, technology's creating some eyes on the ground that weren't available in the past.
Many spheres.
Yes.
Anybody else? Well, hearing no dissension, then, or no questions, we'll, I guess, break. But thank you very much for joining us. And if you have anything else that you just think of right now, just feel free to step up here and we'll try to address it. But thanks very much for attending and have a good evening.